Okay, good afternoon, everyone, and welcome. I'm going to start off today with this population, health, and social justice and injustice presentation with acknowledgements. They always seem to get lost at the end. So I'd like to begin by thanking the people I volunteer with who are committed to changing social injustices. They're the people that keep me going. Also, thank you to SPHERU, the Saskatchewan Population Health and Evaluation Research Unit, where I currently work, the Social Policy Research Unit, the Faculty of Social Work, who helped in an immense way get this underway for today, the Political Science Department, and in particular Tom McIntosh, my supervisor, and of course also I'd like to acknowledge the Saskatchewan Health Research Foundation for the fellowship funding that they have contributed. So the format for today is I thought I'd spend about 20 minutes presenting some material. So I'll talk, and then you talk, and then we'll all talk, hopefully not at the same time. I'm especially interested in whether or not there are some follow-up conversations or meetings that some of you might be interested in. And so this is my email address, and I'd be very happy to hear from you if you're interested in some further conversation about health and social justice. Fiona is going to be tracking some of the comments and questions that come in from the live feed during the presentation. So she'll collect all of those, and then we'll entertain questions, comments, and such after the PowerPoint's finished. And just a note that this session is also being recorded, and we're going to put it on the Social Policy Research Unit website at a later date. So in general then, I'm going to start with a bit of an introduction, and then I'll introduce some of the key concepts as well as some statistics and weave these together. And then I'll offer some conclusions and then some questions for us all to ponder, unless, of course, you have your own questions, and we'll work through those instead. So I'm here today to offer a conceptual exploration of population health and social justice. This is connected to my PhD research and to my 20 years of working and volunteering with a variety of marginalized communities. It's important to note that I'm not a specialist, but rather a generalist, in that I've worked with a whole variety of marginalized communities, including people who are homeless, people with physical or psychiatric disabilities, immigrants and refugees, street youth, etc. So and I'm also very interested in facilitating more of a conversation than a lecture. So, in fact, today we'd started off thinking this would be a neat seminar, but given others from off-campus wanted to participate and at least hear the conversation and the content, this feels more like a lecture, but we'll try to make it not so lecture-ish. So basically then, in terms of an introduction, it's important to point out right at the outset that most of what keeps us healthy lies outside the formal healthcare sector. And historically, major advances in health status have resulted from broad social reforms as opposed to health reforms. Yes, hospitals and doctors are very important, but there are other things that have a bigger impact on our health status, and that's what the nature of this presentation is today. So the key messages that I'd like to offer, and this is basically the last slide, and I've put it right here to kind of orient your thinking. First of all, population health and social justice are indeed inherently linked, even though they sound like very disparate fields. Number two, health inequities exist for a variety of population groups in Canada. Number three, looking at past social determinants are important. We need to look past social determinants and examine some of the structural determinants of health. And finally, major policy tools like human rights codes are intended to reduce inequities, and I'll present a little bit of material on that as well. So we'll start off with a definition of health. Basically, health is a state of complete physical, social, spiritual, and mental well-being, and not merely the absence of disease or infirmity. Health is a resource for everyday life. It is a positive concept emphasizing social and personal resources as well as physical abilities. And so it's intentionally broad, and I'd like to point out that the word spiritual I added as per our Aboriginal communities' conceptualizations and some of the really neat work coming out of Saskatchewan and Alberta around the social determinants of health for Aboriginal communities. Basically, as we look at health and move into this concept of population health, this is but one way to look at population health. It's my attempt to take a very complex field and simplify it. So on the extreme left side, you have a list of determinants of health. And for people like Hancock, Labonte, and Edwards, there's a whole variety of these determinants of health, including sustainable ecosystems of built environments, community supports, cultural continuity, social equity, and in this particular case, I'll be using poverty as a case study, prosperity, human biology, personal health behaviors, and health services. These determinants of health exist in different spheres, including starting very micro level at the individual and then move on to the family, community, and societal levels. And these determinants have reciprocal effects on each other. And it's important also for you, when you look at this list, that health services are at the bottom of the list. Health services do indeed play a more minor role in keeping us healthy when compared to all of the other variables on this list. And social determinants of health look slightly different for different groups of people or different populations. As we move to the middle of the diagram, the population health processes of change over life course and through space is a very important variable to look at because nothing is static and people's health changes over time. So what the Hancock, Labonte, and Edwards model points to is that within population processes of change, there is something called governance, and that includes when people embark on volunteer work as well as things like civic participation, voter behavior, those kinds of things. So it's the active community engagement kind of stuff. And the second major process of change that they talk about is education and lifelong learning kinds of things. So these are the kinds of things that affect us in more of a dynamic nature. So you put the determinants of health plus the population health processes of change together, and then you can look at things like population health status. They can be positive things like people's life satisfaction, sense of well-being, those kinds of things. Negative health status are what I think we're probably more aware of, and they include things like morbidity and mortality statistics. And then there's population health status disparities or inequities. In particular, the effects of poverty is what we'll zero in on. So basically then population health focuses on the interrelated conditions and factors that influence the health of populations over the life course, identifies systematic variations in their patterns of occurrence, and applies the resulting knowledge to develop and implement policies and actions to actually improve the health and well-being of populations. So I'd like us to zero in on one particular systematic variation for today, and that is poverty. And poverty is indeed a determinant of health, as indicated in the previous slide. What I'm going to offer here is a highly simplified description of a very complex field. So a systematic variation here is about certain groups living or more likely to live in poverty. The examples I've cited here include the average income for Aboriginal peoples in Canada hovers around $15,000, but for non-Aboriginal people it is around $25,000 per year. Second example, single mother-led families in Saskatchewan live on $16,000 in social assistance, yet the average family income is closer to $30,000. And finally, a person with a disability receives $10,500, yet an average individual income is $28,800. So indeed, there is some big differences across these different population groups. People who don't have much money, as described in the previous slide, probably also have reduced access to food, reduced access to transportation, reduced access to recreation, increased social exclusion, increased exposure to discrimination, for example, racism, increased stress, powerlessness, and hopelessness. And these are all indeed connected to poorer health, and there's a vast literature on this particular topic. There are indeed multiple factors related to poverty which travel through multiple pathways that influence health. I'd like to just make this become a little bit more alive by citing a portion of a transcript of an interview I had with a person that I had interviewed for my PhD research, and here is his quote. "You see, it's hard to define it. You get used to being, well, no matter how well you take care of yourself on welfare, many people can't do it at all. All the people I know who live on welfare hate it because they just don't have a life. They just know that once a month they get some money and they go out and spend it and live in a ditch the rest of the time, basically, psychologically. They live in a psychological ditch. At least I live in a house. It's not much of a house, and at least I've got bread and margarine. I try to work it so that I don't have to be out looking for food near the end of the month. I hate that. I plan it so that I have only a few glitches each month. It's a supply management thing. I mean, it's a horrible way to live." End of quote. So people living in poverty are likely to have higher rates of illness and death. For example, the infant mortality rate in Saskatoon low-income neighborhoods is 448 times greater than the high-income neighborhoods. Over a 4-year period in Montreal, heart attack hospital admissions were 13,000 for low-income neighborhoods versus 4,600 for high-income neighborhoods. So systematic variations then beg questions about equality and equity. Equality, quite simply, is sameness. Equity, quite simply, is fairness. Inequities are differences which are actually unfair, unnecessary, and avoidable. In Canada, across population groups, there are inequalities and inequities. Here are the concepts applied. Some people sleep here on a mattress on a floor like this, while others sleep in a house like this. This reflects inequality, the lack of sameness, but it also reflects inequity, a question of fairness. Marginalization occurs when there is inequality and inequity, as in the previous photos. Marginalization shows itself through groups of people who are excluded economically, socially, politically, and psychologically. It applies to all similar people. They're created by society, and it persists over time. Social justice is viewed as an attempt to reduce marginalization and involves 4 major dimensions. Probably the most familiar to us is the redistribution of money. However, there are also issues around the redistribution of opportunities for people and redistribution of power. The second dimension is a recognition of the dignity of all people and the worth of all people. Thirdly, there's a participation in society that becomes important. It's the opposite of social exclusion. And finally, Sam Gindin talks about personal capacity development as another important dimension of social justice. Social justice is very much an orientation. It's a loosely knit body of ideas, just like neoliberalism is. Let's just take a moment then to look more closely at neoliberalism and related concepts that run contrary to social justice. Neoliberalism, and when we hear it, we think about private markets, reducing government intervention in our lives, individualism as opposed to community kinds of interventions. It is very much a structural determinant of health. Malali's work on the structural determinants are helpful to us here. He sees structural determinants as systemic, often invisible, and he likes to describe them in terms of 3 major dimensions. Number 1, the dominant ideology of a society. Number 2, institutions. And number 3, social relations. Here's a little bit more detail on his structural determinants on this next slide. Structural determinants foster injustice and ill health. I've just explained dominant ideology. In our particular case, we're talking about neoliberalism. But the second item here is institutions, and in particular government institutions and the policies they make. For example, government income assistance policies create poverty, which is an injustice and leads to ill health. Government residential school policies have destroyed culture and family traditions across Aboriginal communities in Canada. And government changes to their housing policies actually increased homelessness in this country over the past 20 or 30 years. The third dimension that Malali talks about are social relations, and that's about dominant and subordinate relationships that exist in communities. We're familiar with notions of poor bashing and racism. Some theorists actually indicate that structural and political determinants of health are the ultimate causes of health and illness. However, structural determinants can also foster social justice and health. For example, the federal and provincial governments actually reduced poverty rates for seniors with retirement income assistance programs like the Canada Pension Plan and the Old Age Security Program. For example, in 1976, the poverty rate for seniors was 29%, and by 2007, it had been reduced to 5%. There are a number of human rights tools that can actually be used to help change these structural determinants. Human rights tools can reduce inequities and enhance health. For example, the UN Declaration of Human Rights, Article 25, talks about the right of every human being to have an adequate standard of living, a high quality of life, etc. There's also an International Declaration of Health Rights, and that is in this book, labeled Social Injustice and Public Health. And the really interesting part about this particular book is it has a series of international kinds of human rights tools. And in particular, if you look at the International Declaration of Health Rights, it talks about the enjoyment of the highest attainable standard of health. It is a fundamental right of every human being. It is not a privilege reserved for those with power, money, or social standing. And then it goes on to talk about a very broad definition of health, as I alluded to earlier in the presentation. In Canada, there is a Charter of Rights and Freedoms as well, which actually talks a lot about the equality of rights that people have, whether you have a disability, whether you live on a low income or whatever. There is also various types of legislation and policies across the country in various provinces that is intended to reduce inequities and therefore has implications for health. And the one I cite here is an act to reduce poverty and social exclusion, which was rolled out in Quebec, I believe, about 8 or 10 years ago. So we do have a number of tools and policies and legislation that are intended to reduce inequities in our society. In conclusion, I would like to reiterate the 4 major points. First, population health and social justice are inherently linked. They come together when we talk about social determinants of health, systematic variations, health inequities, and marginalization. Number 2, health inequities exist by population groups in Canada. Number 3, structural determinants of health actually shape social determinants of health. So we mustn't just focus on social determinants of health. And finally, major policy tools like human rights codes and other legislation can actually reduce inequities. And the final slide here. Social justice is a matter of life and death. It affects the way people live, their consequent chances of illness, and their risk of premature death. Reducing health inequities is an ethical imperative. We need to encourage adoption of social justice principles and enforcement of human rights in order to reduce health inequities. And that is it for my formal part of the presentation, and I'd be very happy for us to have some conversation, or if you have questions, observations, or comments, we can do that now. And I think Tom will assist with that, because I think we also have Fiona on the video screen for the internet people who are watching. So thank you very much. Thank you for that. The comment made was that there's a whole lack of understanding at the community level around poverty in particular. If children are poor, then indeed they probably have poor parents. There's no other way to look at this. There's stigma and criticism that comes with being poor, and a lack of understanding. I missed your last point. Could you just?
Pretty much that was it. I guess like just real stigma and a criticism of, if you don't want to have poor children, then you shouldn't have them.
Oh, right.
That kind of judgmental, moralistic attitude.
Okay.
And I think it's prevalent in all our policies. It's not just community.
Good point. And you also, now when you said something, you just struck me about the working poor point you made, which is really important. And that was one of the things I was going to raise earlier as well. But if you look at even a $10 an hour job, $10 an hour times 40-hour work week times 52 weeks, you're looking at about $20,800 you're living on. If you happen to be the sole income earner for your family and you're raising a couple of kids, the poverty line for someone living on that is kind of, it's just, it's amazing when you look at those kinds of numbers. And the National Council of Welfare does a lot of this work with all of these numbers. So if you're interested in some of the breakdown and some of these statistics. So thank you for raising the point about the working poor, because people with minimum wage jobs, this is a huge issue. And then, of course, there's a whole, connected to that is a lack of benefits that don't come with it in terms of health care, dental, all of those kinds of things.
Which occurs when children are away from, when children are home.
Okay, so the clarification was added that indeed the working poor, this could also include people who are doing part-time jobs, possibly even night shifts and those kinds of things, so it makes juggling family life and raising children just a bit of a nightmare. Thank you. Other comments?
I'm just curious, what do you want to do with all this? Where do you want to go with what you've been describing?
I'm very interested in pushing, well, again, as I said, if you read something like The Mean Season, which was an analysis around how neoliberalism came to kind of dominate and how it became entrenched in kind of government policy and all of those kinds of things. I'm very interested in seeing how do we rejig that? How do we, who are interested in social justice and social equity kinds of things, how do we rejig things? So I actually, whenever I get a chance to meet with a government department on a particular policy issue, then that's important to me, and I'll be there and I'll point out that these are the kinds of things that we have created, and we need to look at how we do that differently. And sometimes it comes with a small group of us, sometimes it comes with huge groups. I mean, the Quebec Act to eliminate poverty and social exclusion came with the efforts of 1,500 community-based organizations, unions, professional groups that just pushed that over a number of years. So, and maybe it's just the eternal optimist in me, I think there's places where we're making headway. I still think there's an awful lot more to go. And again, maybe the social justice isn't the hook. I'm not sure what the label is. And maybe that's what I look to others for. I mean, some of this stuff, when somebody says at a city council meeting, well, it's only an extra 25 cents per ride, I think. But see, there just needs to be an awful lot of, who said public education? Yeah, public education around how do you help people like that understand. So I came out of that meeting thinking, I got to go meet with that city councilor and point out that actually 25 cents is an awful lot for some people. It may not be for that person, but it is for some people. So that's where I see. So for me, it's an individual and a collective action kind of question that I think is important.
Good. About a month ago, we had a speaker talk about poverty, and we've talked a lot about poverty here. And it comes out to not entirely clear how people define poverty. And I would think that as academics, we could make a real contribution at the way we define poverty. This previous speaker talked about low-income cutoffs. And as long as you have low-income cutoffs, the poverty rate is never going to change because it's a percentage of that. As income comes, it's always going to be there. So, and I think that both there have been some explorations of definition of poverty across ideology, and it doesn't get mixed up with the ideology question. And I think we could make some progress on that as academics, scholars, researchers. Did you?
Okay, I'll give it a try here. Huge question about how do we define poverty, which is really, really it's a huge question. I know right now there is an attempt to mobilize Saskatchewan around a poverty elimination strategy, and that's very much at the forefront. In fact, some of the people in this room are involved in that particular work, and they're asking questions about defining poverty. So the speaker also suggested that even looking at LICO, the low-income cutoff is something that's been around forever. But indeed, what are there, like 8 or 9 different measures of poverty? There's a market basket measure, which is the newest kind of development, I think. Is that right? So and that looks slightly different than LICO, and so there are a whole bunch of different ways that poverty can be measured. And the person here was asking that maybe what as academics we can do is help rejig the definition or push a sorting out of the definition of poverty, and perhaps that's a role that we can indeed play. And I agree with you 100%. And in fact, I often find conversations between what's the qualitative description of poverty and what's the quantitative description, a fascinating kind of conversation, because for someone like me, I mean, I appreciate both the numbers and the stories, but I think oftentimes it's the stories that speak mostly well to politicians for sure. So I would even add to that, how do we do this qualitatively and quantitatively? Did you have a response? Did you want to add to that?
No.
Okay, I thought you were about to say something. Okay. So very, very good point around defining poverty for sure.
Where would you go with it? Where do you see it?
I'm sorry?
Is it on your agenda, or
Okay.
are you looking at that, or where do you see going with it?
Poverty.
Definition of poverty, so we have a common definition.
Okay.
So
So,
how do we know if we reduce it if we don't have a common definition? Show me poverty.
okay, so the question is, where would I go with this redefining of poverty? How do we don't know it if we don't know what it is until we actually can define it. For me, as I pointed out at the beginning, I'm more of a generalist, so I do poverty stuff, but I'm also interested in disability policy as well as kind of homelessness kinds of things. But for me, I think, and I'm going to pick up a point somebody else made earlier, it's not just about the money part, although that's a huge part of it, because I know I've been in meetings where people say, well, we can't just start signing over $20,000 checks. So it's not just about that. And I haven't spent hours and hours like some people in this room have looking at how do you redefine it. So I don't really have a good answer to your question, other than I think some of the work that the Poverty Free Saskatchewan group is now working on might move us in that direction. Fiona?
Suggestion. I think one of the ways that we would want to be more inclusive is to bring in more different modes of communication about what poverty is, and that means getting quite to the personal experience of what it is, so that it's not just a number thing, but it's more an expression, an experience. And so there's different ways of expressing your experience. That could be through art, drama, poetry, narrative. There's a whole range of ways of expressing what poverty is. And I think we need to bring more of those in.
Thank you. So what Fiona was responding with was that there's more that we need to be more inclusive around how we're defining poverty and have a greater range of way to communicate that. There's all kinds of ways that we can explain what poverty is through various experiences and expressing these, for example, through art, drama, and poetry. So, and then perhaps I'll add that might be a way to do the public education thing. If we're not just using newspapers and rolling out statistics, but rather we're doing things like, well, perhaps you may, Fiona, have indicated Photo Voice, which is now Switch, which is all about a visual display, if you will, of how people see the world from their poverty experiences, which it doesn't involve lots of words, but it's very much a visual display of those experiences, way beyond the numbers. So, yes?
One of the things we know that helps people and children and families in poverty is education, because we believe that education leads to opportunities, jobs, etc. However, my direct experience with multiple families in poverty is that, and when I'm sort of talking about how to represent poverty, is these families move 5 times a year, 3 times a year, every other year. The children have inconsistent schooling, which impacts education. And it's because of poverty they're moving. Houses that are condemned, landlord kicked them out because they couldn't make rent. They end up homeless, and they end up in another low rental place that costs $800 a month. I just want to flag that as a real factor, like back to the homelessness and housing kind of stuff you're talking about. But that's a huge piece of, that's another barrier.
Okay, so the person in the audience pointed out that one of the ways we need to kind of remember poverty is it's not just a unidimensional thing, but it's connected to education and opportunity and jobs. However, also embroiled in all of this is when we need to, or some families need to be moving their children because their housing has deteriorated or it's been condemned, so they're forced to leave that particular housing unit. Then they have to move schools, so then there's this whole kind of disconnect that happens to families when they're not kind of kind of connected in their communities. Is that a fair statement? Okay. Thank you. Anything from afar, Fiona? Okay. Okay. Perhaps I'll just point out the very bottom here. My email address, if anybody is interested in furthering some conversations about anything that you've heard today, I'd be more than happy to be continuing this conversation. I didn't want it to be a one-off. So by all means, send me an email, and we'll, I suppose, Fiona, do another kind of broad announcement if it looks like there's going to be a reconvening. And again, it could end up being an academic exercise. It could end up being more an action-oriented piece. So again, I'd very much be interested in staying connected with others who are wanting to further discussions around health inequities and social justice. So I invite you to do that if you see fit. If you bump into colleagues on or off campus that you think might be interested, by all means, just send them my email address as well. So thank you very much.
Thank you, everybody, for coming, and thank you to the people online for coming. Again, thank you to all of our sponsors and to the people who pay Gloria's salary at the Health Research Foundation. And thank you very much, Gloria, for having brought us all together today.
Thank you.
Cheers.